Welcome to the next video in the series on sleep disorder breathing. I want to first mention a disclaimer that I'm not a doctor, I'm not a medical professional, so I encourage you to consult a qualified medical professional and even do your own research. I encourage you to do that as well. To open up part 2 of this discussion, I want to direct your attention to the article on the screen from the Journal of Dental Sleep Medicine. To save time, I'm only going to read and comment on the part that I marked in the red box. But this is a well-researched article, so you can check it out in its entirety if you're interested in that. And he has all the references and the studies that he mentions in the article listed at the end of the article. But let's jump into it. He says, in fact, it is not rare nowadays to hear physicians choose to recommend no therapy to the asymptomatic apnea patients. So as I go through this, I'm going to be interjecting my comments. So my comment on this first part is that this goes right along with what I was saying in the previous part of this video series, that there's a strategy being promoted to wait until the problem gets worse before doing something about it. After a physician determines that a patient has sleep apnea, since the patient isn't suffering from any symptoms yet, the physician simply recommends taking no action. So the patient went through the effort of finding out that he has sleep apnea just to end up in the same boat that he was in before, because no helpful action is being recommended to him. As I also mentioned in my previous video, medical professionals seem to tread lightly around this subject, and as we keep reading here, we'll see how he interjects phrases that soften the blow. But if you really think about what he goes on to say here, it's like he's saying that patients are being forced to spin their wheels for a while before they're allowed to receive treatment that will help them. But I don't think a medical professional would come right out and tell you that. This journal was written by a professional with the purpose of having it read by other professionals, but I wouldn't expect any of my doctors or dentists to be as straightforward as this journal article is. In fact, I would be shocked if they were. Now, moving on, he next says, this has a tremendous implication for our field. Now, that's the field of dental sleep medicine that he's talking about. Why is he saying this? Well, his previous statement was that physicians are recommending no treatment. They're recommending no treatment because they don't deem a CPAP to be appropriate in these cases, since CPAPs are so intolerable that a CPAP would be more debilitating than the patient's symptoms. So this has tremendous implications on his field of dental sleep medicine, because this isn't the case with oral appliances. They are much more tolerable. Notice what he goes on to say next. He says, in the future, and then a little bit later he says, please note that I am just asking these questions and not trying to answer them at this moment. Again, it's like he's interjecting these phrases to soften the blow so that he doesn't raise as many eyebrows, right? He doesn't want to be viewed as being some kind of rebel, but he's still saying what he's saying. So notice what he says. He says, should asymptomatic snorers evaluated by a medical general practitioner continue to be referred to a sleep lab before getting an oral appliance? Could we as dentists treat the asymptomatic snorers without reference to a doctor, provided we are adequately trained? Now, this is the part here that I'm talking about, right here. He mentions the asymptomatic patients, the patients that don't have any symptoms yet, right, but who would like to prevent symptoms from developing, right? So in other words, he's saying maybe in the future, these asymptomatic snorers won't be required to go through this rigmarole before they can get help. Saying in the future, maybe it could be done this other way, to me is really similar to asking if there's any point in the way it is now. So he's proposing the concept of allowing patients to get a custom-made oral appliance to protect their health without having to go through the whole sleep lab thing first. Notice what he goes on to say then. He says this paradigm change would not only democratize the field. Now let's stop and talk about that. Let's think about what he's really saying here. What's the opposite of a democracy? A dictatorship, right? So he's basically saying that this area of medicine is being dictated by authority figures who have the agenda to sell the most amount of CPAPs instead of doing what's best for the patients. Now, he wouldn't be allowed to word it that way, but what else could he be saying by this? Notice what he goes on to say. He says this paradigm change would not only democratize the field, but allow the diminishing number of sleep physicians to concentrate on the difficult cases. Amen to that. I know where I live, if you want to get in to see a sleep specialist, you have to book your appointment 2 or 3 months out most of the time. What's it like where you live? Let's keep moving. He says, allow the diminishing number of sleep physicians to concentrate on the difficult cases, as my colleague, Dr. Michael Simmons, suggested at one of our annual meetings a while ago. Now, what I get from this comment is basically, we said this a long time ago, but no one listens. But seriously, when an asymptomatic patient just wants to get an oral appliance to protect his health, what's really the point of requiring all this other stuff before he's allowed to see the dentist who can help him with this? What's hoped to be accomplished by this other than it's fulfilling a legal requirement and forcing the patient to have to spend more time and money to protect his health? No one has ever been able to explain to me what other result might possibly come of this. What else are we thinking might get discovered during the process? Are we going to find restless leg syndrome? Even restless leg syndrome doesn't typically require a sleep study to be diagnosed. I just don't get it. What's the probability that something else useful is actually going to be detected? Now, these points are really going to be highlighted as I continue to tell you the experience of Beth and myself. Now, I read a book about this, and I'm not going to tell you the name of the book, only because I have some things to say about it that may be perceived as negative, and that wouldn't be fair to the book, because all in all, it's a really good read. Again, I just think that the author had to be concerned about keeping his accreditation, and that's why not everything made as much sense as it could have made. But it was a really good book, and I really enjoyed one of the points that it made. The book said that when you have a hammer, everything looks like a nail. And that's so true in this case, in that when we have these different medical professionals we go to, and from their perspective, the solution to your problem is the service that they offer. But what I can't figure out is why they go to such lengths to convince you that you won't benefit from employing other strategies. The author talked about having a sleep team, as if these doctors are going to work together like a team, right? In reality, though, at least in my experience, the ENT is telling you not to worry about sleep medicine. The dentist, by not even telling you it's an option, is recommending that you not worry about it. But then at the same time, when Beth decided to get a septoplasty from an ENT, her therapist is telling her that a septoplasty is just going to help her to breathe better through her nose. That's like telling someone that if they get heart surgery, oh, it's just going to help your blood move better through your heart. The truth of the matter is that being able to breathe better through your nose can help to reduce anxiety. So we have these early warning signs. And again, what are they? I already talked about grinding of the teeth, but now there's also snoring. That's a big early warning sign. And I want to talk about this a little bit because in our society, snoring is presented as if it's more of a normal thing than it actually is. And it's not presented as if it's a problem. And an example of this is the movie Frozen. I know we've talked on our channel before about Frozen and Disney and different things. But if you think of the movie Frozen 2, it actually has Anna as a child, a young child, and she's snoring. And so for children, that is not a normal thing. That is a problem. Our airways kind of close down as we're getting older. And that's why we tend to snore as we get older. But for a child to snore, that's a problem. That's not a normal thing. And it's actually a problem for anyone to snore. Okay, so you have these early warning signs, and you say, I'd like to look into this to see if there isn't something that I could do that could help me to prevent health problems down the road, help me to stay more youthful. So what do I do? How do I go about doing this? Well, this is where the process gets a little bit more complicated than we might think it would have to be. And to explain what I mean by that, I'll tell you my story. So in my situation, I ground my teeth, right? So I knew that there was a device that, if nothing else, would at least protect my teeth from grinding away. So 100% probability it would help me. 0% probability it wouldn't help me. But yet every credible source that I talked to, my primary care physician, every doctor that I talked to about this, the book that I read on this, they're all pointing me to the same thing, that the best thing for me to do is to take a test that costs thousands of dollars to tell me whether or not I would benefit from something that I already knew 100% chance probability I would benefit from. And so this is what I didn't understand. Even as I was reading the book and it was promoting the polysomnography, it seemed to be contradicting itself. And this is the part that really seemed to be a contradiction, is where it talked about someone who had an AHI of 4 or 5. Now, AHI is the way of measuring how bad someone's sleep condition is. But a polysomnography reveals that their average apneas per hour, even though their overall AHI was 4 or 5, the average apneas per hour during the REM stage of sleep was actually 10 to 12. And based on that information, then a sleep specialist could determine that the situation is actually more serious because the REM stage is getting interrupted, and that's a very important stage of sleep, right? The reason why this seemed to me not to make sense is because elsewhere in the book, he talks about how if you have an AHI of 1 or greater, then you would benefit from a mandibular advancement device. The only gray area would be if you had an AHI less than 1, in which case the sleep specialist could really dive into the data that a polysomnography provides to try to decide if an MAD would still help. So whether the AHI is 4 or 12, I really didn't see the big difference as far as treatment is concerned. Insurance coverage seems to be the biggest difference because the insurance isn't going to cover it if you have an AHI less than 5. But even then, like I talked about before, I really don't think that whether insurance covers it or not should be that much of a consideration for us. But even considering insurance, is there any guarantee that with that extra data that the sleep specialist will actually or will even be able to convince the insurance company to cover it? And yeah, like I said, the cost of the treatment is so close to the deductible to begin with. Why does it make sense to spend all kinds of money in hopes that you'll get enough data to get the insurance to cover it? So to help you understand how this AHI works, which is really important in understanding this, if someone has an AHI of around 30 or higher, then that's where, like, no questions asked, they need a CPAP. A mandibular advancement device by itself won't be sufficient. Now, if someone has an AHI less than 30, then each patient makes his own medical decisions. Each patient really needs to decide, do I think I'm going to be able to tolerate a CPAP, or should I just go with the mandibular advancement device, right? But the closer that the AHI is to 30, the more seriously the patient should consider not only getting the mandibular advancement device, but also getting a CPAP. So from reading this book, I got the idea about this, of how the scale worked. And so I don't understand how this argument about someone having, whether they have a 4 or whether they have a 12, it's not close to 0 and it's not close to 30 either way. So I'm not sure how that makes a difference. So after reading a whole book on this and still being confused about this point, I started calling around to dental offices that were accredited by the American Academy of Sleep Medicine and the American Academy of Dental Sleep Medicine. And I asked the same question. I said, I know I need this because I grind my teeth. But all the information that I'm looking at is telling me that there's all this benefit in getting this expensive test to tell me that I need something that I already know I need. I don't understand. And no one was able to answer my question. They didn't answer my question, so I just kept calling one office after another. Finally, one of the offices that I called actually answered the question, and how they answered it was this way. They said, you know, we really have to be careful how we answer that question because we're afraid of losing our accreditation from the American Academy of Sleep Medicine and the American Academy of Dental Sleep Medicine. And so I really respected that because I felt like that was an honest answer. They actually heard my question and answered the question that I asked in some way, basically being straightforward and saying, we're not going to answer that question. We're afraid of losing our accreditation. So that was the dental office that I decided to go with, and I accepted that I wasn't going to get the answer to my question. So I decided that it must be something that I just don't understand because I don't get the process of how this works. So I decided to spend the money and to get a polysomnography. And Beth did as well. Now, Beth was getting a septoplasty first, so I actually got my polysomnography first. And Beth, on the other hand, because she was getting a septoplasty, her polysomnography was a lot less expensive because she had already met her deductible. I didn't have anything else that needed done. I could breathe through my nose. So for me, this was a really expensive test. And so when it came back, the results came back inconclusive. So because of how long this video was getting to be, I decided to break it up into several parts. If you're interested in health and wellness content, subscribe to our channel. I'll be releasing the remaining videos in the next few weeks, so if you're subscribed, you'll get a notification for those. And leave a thumbs up on this video. Beth and I really appreciate all the support, any of the above, and I'll see you in our next video.